If there is a failure to the medical therapy and you have done some preoperative imaging and a patient is actually reporting to you with a recurrent subacute intestinal obstruction, and you have come up with that there is a stricture somewhere in the small or large intestine, especially when you talk about the small intestine, then you can do the endoscopic dilatation. And in that endoscopic dilatation, one thing to know is that there should not be any acute inflammation accompanying the stricture. Or very inflamed thickened wall of the intestine, because if there is accompanying infection or inflammation, then possibly there can be perforation and the patient can develop peritonitis. So endoscopic dilatation is usually reserved for those patients who have a relapse or have a subacute intestinal obstruction, and you know that there's a stricture somewhere. You exactly know the location of the stricture, and you know that there is no accompanying acute inflammatory process. So you do the endoscopic dilatation, or you can go all the way, you can do a colonoscopy. So first you do the endoscopy, and you should with the help of the endoscopic dilatation, you can see the exact location of the stricture, and then you can the proper diameter of the lumen should be evaluated, and then you can the diameter should be enough so that you can safely place a guide wire, and then you can do the balloon dilatation. And it should be reserved for the conditions in which the stricture is not complicated and it's not accompanied by acute inflammatory changes. Now, if you could see, there are some diagrams which are coming to your screen. So this is actually the endoscopic view, and you can see that there is this is the lumen, and you can see there is a stricture in the middle. And in endoscopic dilatation, what you do is that you insert the endoscope and you visualize the proper location of the stricture. You measure the diameter of the lumen, and then you insert the guide wire. And then after inserting the guide wire, you insert the balloon catheter, and then you inflate the balloon and you keep it there, which is basically the endoscopic balloon dilatation. You can see that was the part actually, and this was the intraluminal narrowing, and because of that, the patient actually suffers of acute intestinal obstruction. And in case of this endoscopic dilatation, there was some of the balloon dilatation was done here in this part, so that it will increase the diameter and it will dilate the part of the intestine. Now, there are some of the complications which can be reported with the use of the endoscopic dilatation. First, if there's acute inflammation, then the chances that you can injure the gut and the patient will suffer from perforation. Second is that there's a possibility that endoscopic dilatation was done, but the patient can again report to you with a stricture formation. So, like you can say, the failure of the endoscopic dilatation can be one of the risk. So you have to keep all these things in your mind while performing whether you go for the operative surgery or you go for the interventional surgery. So first the option is the medical therapy, then the option is the intervention, and if the intervention is failed, then you go for the specific definitive surgery, like you go for, if there's a terminal ileitis, then there's accompanying mass in the ileum, and if there's a proper, if the stricture is present, you go for definitive stricturoplasty. So there is another diagram which is actually showing you the same thing. This after inserting the endoscope, this is the guide wire, and after placing correctly, you can see here this is the lumen which was actually narrowed, and here the dilatation was done, and at least the lumen is better as compared to the previous one. So it's the same thing, but it's a different view. So you can see there is endoscope, and there is that was the narrowing part. This was the narrowest part. Here you can see here as well. So the stricture is being treated with the endoscopic dilatation.